Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, ladies and gentlemen. It gives me great pleasure to welcome you all in our Growth ASPED webinar. I'm Haya Al Khayat, consultant pediatric endocrinologist at the BDF Hospital in Bahrain. I'm a board member and Bahrain representative at ASPED. And today we are glad to have two great speakers who are very well versed in the field. And our speakers are Professor Jesus Argentay from Spain, and our second speaker will be Professor Rasha Tarif. Both speakers will give us great presentations. Each will last for about 30 minutes. And following these presentations, we'll have 30 minutes for your questions and answers. So please write up all your questions in the chat box, and we'll come to the questions later on. You will also receive a CPD certificate 3 working days after this webinar. So welcome all to our seminar, and I'm very glad that we are still meeting and communicating and continuing our professional development in spite of the corona pandemic. So if you allow me, I'll start by introducing our first speaker. Our first speaker is Professor Jesus Argentay from Spain. He's a full professor of pediatrics and pediatric endocrinology. And he's the director of the Department of Pediatrics at the University of Madrid. He's the chairman and at the Department of Pediatrics and Endocrinology at the University Hospital of Neo Jesus. Professor Jesus had more than 500 publications, and he received many awards. Among these awards, you can see that he received SP. He received SP Young Investigator Award and Henning Anderson Prize. And he received the Visionary Award from the Human Growth Foundation in 2020. He lectures in 35 countries in Europe, America, Africa, and Asia. And he's the past president of the European Society for Pediatric Endocrinology in 2002. And he's also the past president of the Spanish Society for Pediatric Endocrinology. So welcome, Professor Jesus, and the floor is yours.
Thank you very much. Can you see the slide? Yes, can you see the slide?
Yes, we can see it, yes.
All right. So thank you very much for this kind presentation. This is a great pleasure for me to be here with you today in this ASPD Growth Webinar on Syndromic Short Stature in 2020. I appreciate your invitation very much. As usual, I'm very happy to share with you our knowledge about the importance of genetics in syndromic short stature in 2020. I have nothing to disclose except once again to invite you whenever we can to whenever we can continue traveling to visit Spain and to see the Arab culture that we have in our country. Here you have a couple of pictures of Cordoba and the mosque, and also the Alhambra Palace in Granada that are beautiful monuments from your culture in our country. So the content of my talk today will be to show you some background about the genetic syndromes associated to short stature, to talk about the progress and evolution we are having in the last years, to show you a personal classification of genetic syndromes, to show you the main clinical features of these syndromes, and to analyze the most relevant syndromes where we have been performed advances in the last years, and finally, the conclusions. So as everybody knows, while genetic causes of short stature were previously thought to primarily be associated with the growth hormone IGF-1 axis, it is now well established that there are multiple genetic anomalies, including different genetic syndromes, not directly associated with the growth hormone IGF-1 axis that can result in short stature. So we are moving then from proportionate short stature to syndromic patients. And a number of progress have been performed in syndromic patients, either with or without microcephaly. A number of programs also performed in syndromic patients with or without intrauterine growth retardation. A number of programs also have been performed in imprinting syndromes and overlapping of clinical features. And finally, we have many progress regarding patients with rasopathies. So the intention of the genetic testing should be to direct the clinical options for management of the growth disorder. So what would be the best term to define genetic syndrome? A genetic syndrome refers to multiple features that develop together, leading to specific and clinical manifestations with symptoms or abnormalities with one known, supposed, or unknown cause. Currently, we know that short stature has been reported in more than 1,300 syndromes, including 300 clinical entities with short stature of prenatal onset, according to the Winter-Barrister Dysmorphology database. New genetic syndromes with short stature are being described, including Mendelian and non-Mendelian inheritance. And finally, we could say that genetic syndromes constitute an important chapter in pediatrics and also in pediatric endocrinology. So what are the main genetic syndromes with short stature? If you try to find a classification in the international literature, it's very difficult to find one. Therefore, I will show you a personal classification that obviously can be discussed and criticized. I would like to show you this classification, but analyzing 4 different chapters. The first one would be genetic syndromes with short stature and intrauterine growth retardation. I will include here chromosomal aberrations, monogenic diseases, including the 3M syndrome, the Bloom syndrome, the Cornelia de Lange syndrome, the floating harbor syndrome, and the Kabuki syndrome, and non-Mendelian inheritance, including mainly the Silver-Russell syndrome. The second chapter will be patients with genetic syndromes with short stature without intrauterine growth retardation. And here we can include chromosomopathies as important as Down syndrome, Turner syndrome, the 18q syndrome, or imprinting syndromes like Prader-Willi-Angelman syndrome, the Temple syndrome, or the Kagami-Ogata syndrome. And finally, the monogenic diseases, including the growth hormone IGF axis with isolated growth hormone deficiency, combined pituitary hormone deficiency, Laron syndrome, some skeletal dysplasias like Léry-Weill syndrome or Langer syndrome, and rasopathies. The third chapter would be genetic syndromes with short stature and microcephaly. And here, things are moving very fast, and we are increasing our knowledge very much regarding the Seckel syndrome. We cannot speak anymore about Seckel syndrome, but Seckel syndrome spectrum disorders, because there are a number of genes involved in the explanation of this pathology. The MOPDI, or also called Tabby-Linder syndrome, the MOPD2, the Meyer-Gorlin syndrome, or better, Meyer-Gorlin syndromes, because we know at least 8 different ones at that moment, and other syndromes. And finally, the fourth chapter will be other syndromes, including the fetal alcohol syndrome and others. So I would like to refer in my talk to the main advances in some of these syndromes included in this personal classification. So the main clinical features that we can find are, first of all, craniofacial features, including microbrachycephaly, cynophrys, arched eyebrows, long eyelashes, nose abnormalities, and teeth alterations. Microcephaly, mental impairment, hearing loss, myopia, cardiac effects, cryptorchidism, photosensitivity, brachydactyly, clinodactyly, short thumbs, and short stature are elements that we should analyze when we are in front of a patient with a genetic syndrome and short stature. Here I would like to introduce the first syndrome, which is the Keuller-Jones syndrome, associated to the Glee-Krapel family member 2, also called GLI2. And we are making a lot of progress in the understanding of this syndrome with an autosomal dominant inheritance, with agenesia of the anterior pituitary, as shown in the MRI here, with bilateral labial cleft palate, and, as I'm showing you here, with lack of response to growth hormone. We recently discovered the loss of function of BMP4 mutation associated with combined pituitary hormone deficiency. This child has an excellent response to growth hormone and also exhibit a number of abnormalities in their hands and their feet. Regarding some skeletal dysplasias, I would like to mention only 2, the Léry-Weill dyschondrosteosis, as shown here in these patients with this clear abnormality in the forearm. We had the opportunity to study a number of families, including this first pedigree with a number of patients affected with the abnormalities in the SOX gene or in the PAR1 region. When the mutations in the SOX gene are in homozygosis, we have the Langer mesomelic dysplasia, as shown here, where you should perform an important skeletal survey in order to analyze all of the problems that you can find in this rhizomelic dysplasia. So how about the 3M syndrome, also called jagged short stature? Well, we can say that these patients exhibit severe pre- and postnatal growth retardation below -4 standard deviation, with some facial dysmorphic features that are very common, including the frontal bossing, the pointed chin, the hypoplastic mid-face, full eyebrows, low nasal bridge, and full lips. In addition, they have some characteristics skeletal features, and also dislocations and joint hypermobility and pes planus. Usually, they have normal intelligence. Today, we know that the cause of this syndrome is the presence of biallelic mutation in at least 3 different genes: CUL7, OBLS1, and CCDC8. How about the Bloom syndrome? The Bloom syndrome also exhibits short stature, but one important thing here is the presence of chromosomal instability with the predisposition to development of cancer. and also with the presence of photosensitivity, telangiectasia in nose and cheeks, mild immune deficiency, and this syndrome is caused by mutations in the BLM gene, and a number of mutations have been discovered as shown in the upper right part of the screen. This gene is located in the long arm of chromosome 15 in the region 26.1. About the Cornelia de Lange syndrome, which is one of the oldest syndromes that pediatricians know well. Well, in 2004, Krantz and co-workers, they just published the first evidence of mutations in the gene NIPBL. This gene, mutations in this gene affect approximately 50% of patients with Cornelia de Lange syndrome. NIPL produces a protein which is part of the complex of cohesin and will explain the abnormalities in the articulations of these patients. Later on, in 2006, Musio and co-workers published the first mutation in patients with Cornelia de Lange X-linked with abnormalities in the gene SMC1L1. First of all, these abnormalities were described in 4 males and with a phenotype that it was very clear, very similar to the Cornelia de Lange syndrome due to abnormalities in the MIPBL. One syndrome that is of great interest, where we have performed a lot of progress, is the floating harbor syndrome. The phenotype of these patients include atypical craniofacial features with low birth weight, normal head circumference, short stature, the presence of brachydactyly, claveling, clinodactyly, and short thumbs as shown here, prominent joints, clavicular abnormalities, severe language impairment, hypernasality, and high-pitched voice, with intellectual disability going from mild to moderate, and hypospadias and/or undescended testes. The differential diagnosis of the floating harbor syndrome should be done with Russell syndrome, Rubinstein-Tavis syndrome, and 3M syndrome. Today, we know that the floating harbor syndrome is an autosomal dominant disorder due to heterozygous mutations in the gene SRCAP. The majority are de novo, and prenatal diagnosis can be performed. More recently, we have learned from Legolf and co-workers that not all floating harbor syndrome cases are due to mutations in exon 34 of the gene SRCAP, as shown here. So it seems like it means that we need to perform more research in order to know another potential genes that could be involved in the diagnosis of the floating harbor syndrome. Another syndrome of great interest is the Kabuki syndrome. These patients saw a distinctive facial appearance with cardiac anomalies, more than 50% exhibit short stature, with moderate intellectual disability, and they exhibit mutations in the MLL2 gene, approximately 75% of these patients. And this is an autosomal dominant disorder. So the first evidence of these mutations were shown in 2011. Later on, we know that according to the studies by Mijake and co-workers in 2013, that some patients with Kabuki syndrome have abnormalities X-linked due to mutations in the gene KDM6A. And these patients saw growth retardation with skeletal abnormalities and moderate intellectual disability. So how about patients with short stature and microcephaly? This is a very interesting chapter where we are making a lot of progress during the last 15 years, and especially during the last 5 years. Here, I would like to include 3 main chapters. First of all, the second syndrome spectrum disorders, also called SSSD. Secondly, the microcephalic osteodysplastic primordial dwarfism types 1 and 2, and the Mayer-Gordon syndrome, where, as I mentioned before, we know today 8 different syndromes. Let's see a little bit the most important aspects of these 3 chapters. Regarding second syndrome spectrum disorders, I'm showing you the data from OMIN 2020, including all of the genes that have been involved so far, many genes. So the clinical findings in these patients include microcephaly and short stature. The brain imaging is showing reduced brain volume with grossly normal architecture. The family history, so the existence of an autosomal recessive inheritance. And regarding the molecular genetic testing, we can say that given the high heterogeneity of this spectrum, the best molecular approach is the use of an AGS panel containing all known genes or a full exome in order to analyze potential new candidates. All genes involved in SSSD have relevant roles in cellular processes that regulates the cell cycle, including monitoring DNA damage, mitosis kinetics, and checkpoint control, the centrosome cycle, and organization and function of the mitotic spindle. The alteration of these proteins results in similar phenotypes, and this is the reason why NGS panel containing all known genes or a full exome must be done in order to have a proper molecular diagnosis. Here I'm showing you one patient from our department with a second syndrome due to an SMC5 mutation. Showing here, the microcephaly was around -2.4 standard deviation, severe short stature around -7 standard deviation with learning difficulties, and the phenotype with this face long and narrow with a slight epicanthal folds, prominent nose, and slight low set ears, as well as high palate. This patient saw a mutation in this SMC5 gene, exon number 9, as shown here. Another example with severe microcephaly and ciliopathy is due to PLK4 mutations. Here I'm showing you a family studying our department from Equatorial Guinea, in which you can see a tremendous microcephaly around -10.5, -11.2 standard deviation, and a severe short stature, -4.7 or -7.1 in her brother. So centrioles and microtubule-based structures that form the core of the centrosome and nucleate cilia and flagella. We know that. Centrioles are key components of cell division, signaling, and motility. Mutations in the master regulator of centriole duplication include the PLK4 kinase. And these patients show microcephalic primordial dwarfism that could be associated with chorioretinitis, retinopathy, and blindness. Reduced PLK4 activity results in impaired centriolar duplication and leads to impaired mitotic spindle formation in a subset of cells. The cerebral cortex is reduced, and sometimes they exhibit, as shown here, either pachygyria or lissencephaly. Regarding the microcephalic osteodysplastic primordial dwarfism, type 1, also called Tabby-Linder syndrome, these patients show prenatal onset growth retardation with microcephaly, neurodevelopmental abnormalities, sensory deficits, and intellectual disability, and the cause is due to biallelic mutations in the RNU4 attack gene. Regarding type 2, they also show intrauterine growth retardation with severe proportionate short stature, microcephaly, and a variety of bone abnormalities, being the cause the presence of homozygous or compound heterozygous mutations in the PCNT gene. The 8 syndromes producing Mayer-Gordon syndrome are represented here. And we can say that these patients exhibit genetic heterogeneity with at least 8 genes identified that are encoding proteins in the pre-replication and pre-initiation complexes and cell cycle regulators. All but one, number 6, being inherited in an autosomal recessive manner. Individuals with this syndrome type 1, due to ORC1 gene mutations, are significantly shorter and have more severe microcephaly. So we don't know the exact physiopathological mechanism of this syndrome. However, we know that they have a decreased cellular growth. And the functional studies show a defective rate of primary cilia formation and abnormal regulation of the centriole and centrosome duplication in cells of these patients. In terms of research, during the last year, we are learning more about overlapping of clinical features regarding important syndromes like Silver-Russell syndrome, Temple syndrome, and Prader-Willi syndrome. You know, looking at this Venn diagram, you can see that these syndromes overlap with some clinical issues, including early puberty, clinodactyly, protruding and prominent forehead, SGA, etc. What is important here is to analyze the different DMRs, including in patients with Silver-Russell syndrome, the IGF2 gene and the H19 gene. Regarding Temple syndrome, the DLK1 gene also associated its mutations with central precocious puberty and the gene MEG3. And finally, regarding patients with Prader-Willi, it is important to analyze the SNRF domain in order to better understand the molecular basis of these different syndromes. Progresses have been made regarding vasopathies, and today we knew at least 13 genes able to produce a Noonan syndrome. 4 more genes have been included recently, and in summary, we can say that about 50% of these patients exhibit mutations in the gene PTP-N11, and the new gene discovered, LCTR1, is similar in frequency, its mutations, to RAV1 and RID1. So there is a correlation with a specific Noonan phenotype and different gene mutations. And this is the reason why it's so important, once we recognize clinical information about Noonan syndrome, to perform a proper molecular diagnosis. Here I'm showing you 3 different patients from my department with Noonan syndrome due to LCTR mutations. And as you can see, you have different auxological patterns. This patient is growing absolutely normally according to his target height. This patient is growing very badly. And this patient, we need to know whether he will continue growing well or not. So in summary, not every patient with Noonan syndrome exhibits short stature, but some of them exhibit a very pathological short stature, and they could benefit of growth hormone therapy at that moment. So in conclusion, regarding syndromic short stature, looking at the present and the future, we can say that genetic syndromes refer to multiple features that develop together, leading to specific clinical manifestations, including symptoms or abnormalities with one known, supposed, or unknown cause. Second, short stature has been reported in many syndromes, including 300 clinical entities with short stature of prenatal onset. Third, new genetic syndromes with short stature are being described, including Mendelian and non-Mendelian inheritance. Fourth, because genetic syndromes with short stature constitute a very important chapter in pediatric endocrinology, our efficiency must be increased to obtain a proper diagnosis. And finally, we need to improve our current knowledge in microcephalic syndromes with chromosomal instability. I would like to thank my colleagues at the Department of Pediatric Endocrinology at the University Hospital Niño Jesús in Madrid, Spain. And I also would like to thank all of you. This is a very nice picture that I keep with my slides in my heart when I visit Abu Dhabi last February during your ASPED meeting. And I would like to thank all of you for your attention. So, Shukran min Hispania. Thank you very much indeed. Gracias. Thank you for your attention.
Thank you very much, Professor Khasis, for the great presentation. We've learned a lot from you, and I'm sure that many of you have questions, but we'll keep the questions till the end. And now allow me to introduce our second speaker, Professor Rasha Tarif. Professor Rasha is a professor of pediatric endocrinology at Ain Shams University in Cairo. She is one of the founders of ASPED and the current ASPED vice president. She is the chair of the Education and Training Committee of the European Society for Pediatric Endocrinology. She's an invited speaker and faculty member in various local, regional, and international conferences. She sits in a number of advisory and editorial boards, including the GPEM, and she is an editorial board member and the newsletter of the GPED. Her main area of interest are growth, puberty, bone disorders, ESD, and obesity, and she has many publications in these fields. She was awarded the Best Student in SPU Winter School in 2006 and hosted 2 SPU Winter Schools in Egypt in 2008 and 2018. So welcome, Professor Rasha, and the floor is yours.
Thank you very much, Haya, for the kind introduction. Thank you very much. Can you please tell me whether my screen is shared, because I had an internet problem at the beginning of the webinar?
Yes, it's clear.
Yeah, is it working?
Yes.
Okay, before starting, I'd like to thank you, Haya, for joining us to moderate the webinar. And I'd like to thank Khasis for accepting the invitation to join our ASPED Growth webinar and giving this great lecture. Also, I'd like to thank Sandoz Egypt for supporting this webinar and Folder Company for organizing the event. Khasis gave us a very nice dose of molecular genetics and rare syndromes. I'll go a bit down. I'll go to the Turner syndrome, a very common syndrome that we as pediatric endocrinologists see. And I'm focusing on optimizing the final outcome in girls with Turner syndrome. Of course, Turner syndrome is a common cause of short stature in girls due to abnormal or missing X chromosome. This is the SHOX gene. And we all know that the typical features of Turner are the short stature and ovarian dysgenesis, but there are a lot of other comorbidities in addition to dysmorphic features affecting the quality of life of those girls. And these are some sentences quoted from real Egyptian Turner girls. Laila says, "I won't go to school anymore. I'm much shorter. I look different. I'm teased and bullied all the time." And Mona says, "Why don't I have my periods like other girls? Why do I need to take medications all the time?" And Farida's moms asks me with tears, "Won't my daughter be able to have children?" And Sarah says, "Why do I have a lot of medical problems? I do hate my life." And these are real quotations from Egyptian Turner girls. And a lot of other sad stories that makes us pay a lot of attention to girls with Turner syndrome. So the question is how to optimize the final outcome in girls with Turner syndrome. And this is a real challenge because we have some obstacles ahead in such girls. First of all, the late diagnosis, and this is a real challenge. Of course, the short stature, delayed puberty, fertility and reproductive issues, congenital anomalies, cardiometabolic risk factors, and the social and psychological problems. And these are the main targets or the obstacles that we need to overcome in such girls. Indeed, most of Turner girls are diagnosed late. And let me start by this very classical stories that we in Egypt and I think in the Middle East see quite a lot. This is a 14-and-a-half-year-old girl who presented with delayed puberty. She was very short, minus 3.8, but the parents were not bothered about the short stature. They came because of delayed puberty. Her target height is low. Her parents are short. Her birth weight was 2.2, the length 47. She's not dysmorphic a lot, as you see. All what she had is the low posterior hairline and some nevi. And here you can see the typical upcurved nails. Apart from this, nothing else in that girl except being short. Her thyroid and growth hormone stimulation were normal. Celiac screening done was positive, and this was accidentally discovered and confirmed by biopsy. She had a high FSH and LH, and this was done before doing the karyotype by the pediatrician because she had delayed puberty, and it was too late when the karyotype done being a 45X Turner girl. Her bone age was delayed, 10.5, and she's 14.5. As you see here, she has short 4th and 5th metacarpals, typically infantile uterus and streaked gonads. At this point, nothing else to be done. The growth hormone was started at 0.05 milligram per kg per day, and sex steroid started 1 year after the growth hormone. Of course, this is not the typical, but time was short. We had to do this, and she was put on a gluten-free diet. Unfortunately, starting growth hormone didn't show a good response. She had a poor response to growth hormone. Sadly, her final height is 135. She has regular menses on sex steroid, and this is really a sad story, but quite common. So the conclusions from this girl are: parents sought medical advice due to delayed puberty and not short stature, and this is a cultural problem that we have. Parents thought that she will catch up her height when she hits puberty, and a lot of parents think so. Late diagnosis due to absence of typical dysmorphic features, and this is a very important point. Celiac disease was accidentally discovered and treated, while hypergonadotropic hypogonadism is a very important clue here. The poor response in that girl was due to late start of growth hormone, short baseline height SDS, poor genetic potential, and untreated celiac disease. So I think the start in Turner syndrome is the early diagnosis. If you are lucky, you're going to see a lot of Turner phenotype. But please don't wait for the typical dysmorphic features in Turner syndrome, because there's a large proportion who are not typically dysmorphic and turn out to be Turner syndrome. And variability in the phenotypic features of Turner syndrome leads to delay in the diagnosis. And some Turner girls exhibit very mild phenotypic features, like the girl I showed you. So the question is when to suspect Turner syndrome. You can see here in these two boxes when karyotype is indicated. A short girl with any of the features that you can see here, especially if there is delayed puberty, infertility, left-sided cardiac defect, renal anomalies, or any of the features that you can see in these two boxes. Another story is a 4-year-old girl who came with short stature, and again, she's not typically dysmorphic. She's short, but not very short, minus 2.3. Her target height is excellent. I remember the mother was 170 and the father was 190, and that's why she's a tall Turner. Her weight, birth weight, and length were okay. The thyroid was normal. The peak growth hormone was lowish. It's not low. Celiac screening negative. And karyotype was not done in that girl by the pediatrician because she's not dysmorphic and she's not very short. The bone age was 2 years delay, and the pediatrician decided to start growth hormone on the growth hormone deficiency dose, 0.025 milligram per kg a day. And here, as you see, the growth response was not adequate in that girl. Now, the family traveled outside Egypt and returned to her pediatrician at the age of 17. She came with primary amenorrhea, pubertal arrest, mild clitoromegaly, and she's still short, and she's still on the previous growth hormone deficiency dose that she started before leaving Egypt. Again, her FSH-LH were high, estradiol is low, she has typical hypergonadotropic hypogonadism, but the free testosterone was high, and it was done because the girl has got clitoromegaly. So why does this girl have clitoromegaly and a high free testosterone? At this point, she was referred to a pediatric endocrinologist. And here, the karyotype too late was done 45X, 46XY. And this is a real story that I am telling you. And the FISH analysis confirmed the presence of Y chromosome in that girl. And when ultrasound was done, there was a large solid lobulated mass arising from the right gonad, proved to be a dysgerminoma. At this point, gonadectomy was done, growth hormone was adjusted on the Turner dose, and she started sex steroid replacement therapy. And this is a true story. The girl was diagnosed very late. So the conclusions from this girl are late diagnosis, again, due to absence of typical dysmorphic features. Growth hormone deficiency dose was given with a poor growth velocity because Turner girls need larger doses, being growth hormone resistant. She's not too short due to good genetic potential. And please put this in mind. It's very important to correlate the height of the child to the midparental height. Primary amenorrhea was the clue here. And of course, any Y chromosome material in karyotype should be confirmed by FISH analysis, because as you've seen, it could lead to gonadoblastoma or dysgerminoma. There is a lot to say on the genomic understanding of Turner syndrome, but to simplify it, there's a missing X chromosome, skewed X inactivation with SHOX gene underexpression, leading to global hypomethylation and global differential expression in the RNA and differential protein interactions, all leading to the typical phenotypic features of Turner syndrome. Indeed, short stature is a key feature in Turner syndrome. It occurs in nearly all cases. Most of them are born SGA with a mesomeilic type of short stature. The growth deficit affects the lower limb more than the upper limb and vertebrae, and typically the bone age is delayed around 2 years. If you find more than 2 years delay, exclude celiac and hypothyroidism, and they have a disproportionate increase in weight. So the short stature here is due to haploinsufficiency in the SHOX gene, and they are growth hormone resistant, and therefore they need larger growth hormone doses. Of course, growth hormone stimulation test is not required. And the reason the previous girl that I presented did not gain height, because she was given the growth hormone deficiency dose. So the SHOX gene mutation or deletion leads to short stature and skeletal features, in addition to premature growth plate fusion, ending by disproportionate short stature in those girls. And these are the typical skeletal features that we all know: the short metacarpals, the scoliosis, and the Madelung deformity. Another important part in Turner syndrome is the streaked gonads due to absence of one X chromosome, leading to accelerated loss of oocytes from the ovaries after 18th week of fetal life and over the first postnatal months and years, until they are totally gone by 2 years of age, ending by hypergonadotropic hypogonadism. Around 5 to 10% of Turners still have follicles and undergo spontaneous puberty. In those, about 2 to 8% will have a high incidence of miscarriage if they get pregnant. And these are the predictors of ovarian insufficiency in girls with Turner syndrome: high gonadotropins, especially FSH, low anti-Mullerian hormone, and low inhibin B. We tried to assess at Ain Shams University the anti-Mullerian hormone levels in patients with Turner syndrome and to relate it to the karyotype and spontaneous puberty and therapy. And this was published in American Journal of Medical Genetics in 2018. And here you can see that the cutoff was around 2.6 nanogram per ml, and the lowest anti-Mullerian hormone was in the 45X karyotype, the highest was in the mosaic, and the other karyotypes laid in between. Also, the higher the Tanner stage, the higher the anti-Mullerian hormone in those girls. Not only growth, of course, there are a lot of cardiometabolic risk factors like dyslipidemia, impaired glucose tolerance, hypertension, premature ovarian failure, anthropometric disproportion represented by a very low lean mass and a high fat mass, in addition to growth hormone resistance or deficiency, ending by a lot of cardiovascular risk factors. We also investigated the prevalence of multiple forms of autoimmunity in Egyptian girls with Turner syndrome and its relation to karyotype. We screened the antimicrosomal, the antithyroglobulin, celiac, anti-GAT65, and anti-adrenal antibodies. The highest was the hypothyroidism, autoimmune, followed by Graves. No cases with Addison were reported in our cohort, and celiac came next after the thyroid, and only we had one case of type 1 diabetes. But the presence of positive serology was much more prevalent than the presence of actual disease in those girls. Also, as it's known, isochromosome Q had increased prevalence of antithyroid antibodies and anti-GAD as well. Cardiovascular defect is a major entity in girls with Turner syndrome. Around 1/3 of these girls have got cardiovascular defects, and left-sided cardiac anomalies are the most common. It's very important to alarm the cardiologist to exclude Turner in girls with left-sided cardiac anomalies. Sometimes the cycle starts at the cardiologist, not at the pediatric endocrinologist clinic. We also studied renal anomalies in girls with Turner syndrome, and we compared scintigraphy to ultrasound. Horseshoe kidney was the most common abnormality in Egyptian Turner girls, and we found that renal scintigraphy is not superior to ultrasound in detection of renal anomalies, but it is a reliable method for detection of renal malfunction in Turner girls, especially 45X. Another story, quite common as well, is an 8.5-year-old girl who came with mathematical problems at school. She also had recurrent otitis media. She was slightly dysmorphic, but not a lot. She's short, not very short, -2.5 standard deviation, and the target height is high, +1.5. Her birth weight is fine, the length is 49, and her pediatrician ordered thyroid function tests. He found a low T4, high TSH, great, this is primary hypothyroidism, positive antibodies. He was very happy. He diagnosed Hashimoto thyroiditis, and he started thyroxine here. But the girl did not improve in height in spite of normalization of the thyroid function. At this point, the girl was referred to a pediatric endocrinologist. Her peak growth hormone was normal. Of course, she did it for health insurance, but she was not supposed to do this test. Celiac screening was negative. The bone age is 3 years delayed, and she had ectopic kidney by ultrasound. So what else is missing? The karyotype, again and again. She did not do a karyotype from the beginning because she's not dysmorphic. She had a 45X46 isochromosome XQ. And she was put on a Turner dose of growth hormone daily. And at this point, when growth hormone was added, the girl grew beautifully and is doing fine. And this is a nice story, a good ending. She has a good final height, 155. She's a tall Turner. Probably her parents are very tall. Regular menses on sex steroid, and the thyroid functions are normalized on 50 micrograms thyroxine. So this is a happy ending. The conclusions from this girl are delayed diagnosis again and again due to mild dysmorphic features. She's not too short due to good genetic potential. Her growth velocity improved only after adding growth hormone to thyroxine. Delayed bone age more than 2 years due to associated hypothyroidism, and ectopic kidney was accidentally discovered only after the diagnosis of Turner syndrome. So the question is how to overcome the obstacles that we have seen. Of course, the management plan includes growth hormone therapy, sex steroid replacement, fertility preservation issues, screening and treatment of metabolic disorders, congenital anomalies, and very important social and psychological support. And this is what I call the orchestra to maintain the perfect outcome in girls with Turner syndrome. It's not just correcting height or short stature. And that's why Turner girls need a multidisciplinary team to manage them, not only the pediatric endocrinologist, a lot of other specialties being involved to offer proper management. We all know, indeed, growth hormone in Turner syndrome increases the growth rate and the final adult height, and the response is variable. This is a very old article published in Hormone Research in Pediatrics, where the estimated benefit in the final height ranged from 5 to 9 centimeters. Now, this is a very recent article assessing the final height in girls with Turner syndrome, comparing those who were treated to those who were not. And this is very recent, published in 2019, and they assessed 73 girls with Turner syndrome. As you see here, the curve on the left side here is for the girls who took growth hormone, and the one on the right is those who did not receive growth hormone. The chart in the dots is for the normal, and the one below is for the Turner. It's clear that the final height was much better in those who received growth hormone than those who did not. And the mean difference here, you can see 143 compared to 152 in the treated group. Again, the response is variable. And they assessed all predictors of growth outcome in girls with Turner syndrome. They found that the height SDS at the start of treatment and the mid-parental height SDS were the strongest predictors of the final height in Turner syndrome. Another article published in JCAM assessed the impact of growth hormone supplementation on the final height in Turner syndrome, and they found around 70 centimeters difference, around plus 1.1 standard deviation in the adult height when growth hormone was given. Also, a double-blind placebo-controlled trial classified Turner into 4 groups. A group who received placebo, a group who received growth hormone only, a third group taking sex steroids only, and a fourth group taking both growth hormone with addition of sex steroid. And the best outcome was in the growth hormone estrogen treated group, and approximately 5 centimeter difference that was significant. Now, looking at the clinical practice guidelines for care of girls and women with Turner syndrome, published 2017, there is a moderate recommendation to start growth hormone therapy around 4 to 6 years of age, preferably before the age of puberty or at any time if there is evidence of growth failure. And this is a Korean study that assessed response to 3 years growth hormone therapy in girls with Turner syndrome. They found that the earlier the age of start of growth hormone, the better the height response, as you see in this chart. And they compared the 3 years of therapy. The highest increment in height was in the first year. The second year showed significant increment, but less than the first year. And in the third, there was a non-significant increment. Another article found that there is a significant growth velocity increase, mainly in the first 2 years, that declined later on, but still better than the pre-treatment growth velocity. So the best is the first 2 years. Also, a strong recommendation of the suggested dose for Turner syndrome is 0.045 to 0.05 milligram per kg per day, up to 0.068 milligram per kg per day if the adult height will be compromised, of course, 7 days per week. And this is the famous Dutch Turner dose oscillation study that compared 3 doses being given to Turner with sex steroid added after the age of 12 in the 3 groups. It was clear that the higher the growth hormone dose, the higher the change in the height SDS. Of course, the earlier the age of start, the better the response. Another old study found that the duration of treatment was the strongest predictor for the final adult outcome. So fitting the pieces from all the previous studies, what are the parameters for successful growth hormone therapy outcome in patients with Turner syndrome? First of all, a taller baseline height at initiation of therapy is very important. Good genetic potential, and I showed you this very clearly in the cases. Early start of growth hormone at the age of 4, larger growth hormone doses, increasing the growth hormone to overcome the waning effect of growth hormone, longer duration of treatment, and longer period between growth hormone and induction of puberty, around 4 years minimum, except if you have no time and the height will be compromised. Not only height, growth hormone reduces the cardiovascular risk factors in girls with Turner syndrome, improving the lipid profile, blood pressure, composition, cardiac parameters, and proportions, ending by a better quality of life in those girls. Again, there is a strong recommendation to give concomitant oxandrolone therapy above the age of 10 in a dose of 0.03 to 0.05 milligram per kg per day. But there are specific indications of adding oxandrolone. Of course, it's not a routine thing to do. If the diagnosis of Turner and initiation of growth hormone treatment is delayed, or severe short stature and the adult height is going to be unsatisfactorily short with the standard growth hormone dose, in such a case you have to add oxandrolone. Of course, it's important to monitor for signs of virilization, breast development, and the blood lipid. What about sex steroid replacement therapy in girls with Turner? It's not only puberty. There is a lot to say about sex steroid in Turner. It improves longevity, cardiovascular, metabolic changes, liver, sexual function, and the musculoskeletal system. And there's a moderate recommendation in the clinical practice guidelines to start estrogen replacement between 11 and 12 years and increase gradually over 2 to 3 years. Another article published in JCAM 2018 recommended starting sex steroid at the age of 11 to 12 until the age of 50, and to start with a low dose and increase gradually. They clearly stated that it is not recommended anymore to start the very low dose estrogen in prepubertal period or to delay estrogen replacement until 15, which was done in the past. This is not recommended due to its deleterious effect on the bone and uterine health. So the proposed age is 11 to 12. They also suggested the low dose transdermal estrogen E2 if available. If not, the second choice is oral micronized estrogen or intramuscular, or when not available, ethinyl estradiol. And this is the estrogen replacement regimen in adolescents with Turner syndrome according to each type equivalent dose. And we add cyclic progesterone 1 to 2 years after induction, or when breakthrough bleeding occurs, or once a dose of 15 micrograms a day of ethinyl estradiol or equivalent is reached. Now, this is a survey that was recently accepted in the journal this year, 2020, Journal of Pediatric Endocrinology and Metabolism. I'm so glad to share this with my dear colleagues, Asma Deeb, Abdelhadi Habib, and Hussein Safar. What we did is that we conducted a survey on the timing and regimen of puberty in children with hypogonadism, and we focused on the practice in Arab countries. Now, if you look on the left here, you can see the Arab countries that were included in the survey. And here on the right, you can see that most of the physicians and endocrinologists chose 12 years to start estrogen therapy in Turner, but still there was a variable age of starting estrogen in Turner girls in ASPED countries, as you see in this bar chart. We also found that there was a variable use of estrogen and progesterone preparation in ASPED countries, and there was a variable timing of adding progesterone in ASPED countries. Again, if you look at this table, these were the questions that we asked the respondents here. Which estrogen preparation would you use to induce puberty? When would you add progesterone? And which of the following forms would you like to use? Again, a lot of factors affected the answers of the respondents. We also assessed uterine development in patients with Turner syndrome and its relation to karyotype and hormone replacement therapy. We found a positive correlation between uterine volume and each of duration and dose of estrogen. And we concluded that patients with Turner syndrome treated with estrogen in adequate dose and duration may attain a normal, mature uterine size, even with the late start of treatment and regardless the karyotype. Fertility and pregnancy issues. In Turner, a lot of research on that. There is assisted reproductive techniques with oocyte donation, and some references mention that the rates are in Turner syndrome are comparable to the general population. Also, oocyte preservation is an option, but no reliable data outcome on that. And the final step, the handover. Transition from pediatric to adult care needs special attention. It's very, very challenging taking them from pediatrics to adult. And I'll finally end by this case that teaches us to look for the uncommon. I'll be very fast. This is a 5.5-year-old girl who was preterm, small for gestational age. She has global developmental delay. She's epileptic, social and behavioral problems. She's not very short, her target height is very high, and as you see, she has webbing, low posterior hairline, and this is the typical scoliosis and funnel chest. As you see, she's not short at this time. The karyotype revealed mosaic Turner 45X47 XXX, as you see, and FISH excluded Y chromosome. At this point, the bone age was 5 years and the girl is 5.5, and she had a prepubertal uterus and ovaries. And this is to show you the X-ray of her lumbar spine. Would you like to give growth hormone at this stage? I think the answer is no. The girl is not short. She has severe scoliosis and financial purpose. And then she came at the age of 6.5 years with vaginal bleeding once, and she jumped in her height, and she was in tenor breast stage 3, P2, A1, and she was referred from the genetics clinic to our clinic. Here you can see how the growth of that girl jumped up. And this was the first time when I first saw that girl, when everything looked so strange in that girl. She's a mosaic Turner 45X, 47XXX, starting with normal height and growth velocity, going to precocious puberty, accelerated growth velocity with other features that are not common with Turner syndrome. So what's going on in that girl? Here you can see the GnRH showed FSH being high, LH being high, estradiol high, and the uterine ovarian volumes were high as well. She entered into puberty. So we have a case of 45X, 47XXX Turner with central precocious puberty, very unusual. And when we checked the literature, we found only one case exactly similar to our case. And there are other 8 case reports, but different other mosaic karyotype, only our case and another one who had this XXX karyotype. Of course, there's a genotype-phenotype correlation when you have deletion of entire short arm. This is a full Turner phenotype. Deletion distal to XQ21, no effect on the stature. So the presence of short arm of X chromosome maintains the stature. Loss of a region at XP22, short stature, neurocognitive problem. Region XP11-4, critical for lymphedema. And for ovarian function, most important is XP11, proximal, is more important for ovarian development than its distal part. Isochromosome, of course, increases risk of hypothyroidism and inflammatory bowel disease, and ring chromosome increases the risk of mental retardation. So what happened here, a cell line with X chromosome monosomy and cell line with 3 copies of X chromosome suggest a post-zygotic unbalanced disjunction of sex chromosome with quantitative proportion of 45X to 47XXX cell line in different tissues and organs. And this was the cause of precocious puberty and other uncommon features like height and psychological problems, ending by precocious puberty in that girl. And these are the features of XXX. Some of them were found in that girl, which are not typical for Turner, but due to the presence of XXX. The question, would you like to start GnRH analog at this stage? Again, when I checked the literature, no results. There was no clear line to follow in such a condition. And would you like to give growth hormone at this stage? And what dose? Another really puzzling question. In the case similar to our case, they gave GnRH analog and growth hormone, and the final height was 149. And the updates in our case is we gave GnRH analog. She resumed menses. She was given growth hormone therapy. Scoliosis did not worsen. And don't ask me why, because I don't know the answer really. Scoliosis didn't worsen a bit. And the bone age was 13. Her near final height is 151. And I'm sure you all have a lot of Turner stories, and most important is expanding the support network for Turner, like natural registries, avenues for Turner, patient supporting group. And finally, this is a personal story by Triona Keane, My Life with Turner Syndrome. She's a Turner syndrome lady diagnosed with 45X. She wrote a book on herself. She's a very successful lady, 28-year-old woman, getting on with life. She's a health officer. She loves singing, drama, and she's fit in her spare time. And what she said is that the journey ahead no longer frightens me. And she decided to write her story as a model for all Turner girls to increase the awareness, because early diagnosis and management of girls with Turner syndrome is important to improve the quality of life of those children, to see the happy faces of those sweet, lovely girls and young ladies. Thank you very much for your attention.
Thank you very much, Professor, for this comprehensive presentation on Turner syndrome. And as you mentioned, most of the cases of Turner syndrome, unfortunately, they present very late. Although the teaching is whenever you suspect Turner and any short girl, even without any phenotypic features, you have to do the karyotype.
Yeah.
Thank you very much. So now, thank you, Rasha. Now we'll go to questions and answers. And mashallah, there are plenty of questions. The first question is, how do you manage short stature in these syndromes? Is there clues as to whether growth hormone is effective? This question is Professor Jesus.
Yeah, this is a very important question because some patients, for example, with rhasopathies, they could benefit from growth hormone therapy. However, other patients with Bloom syndrome, for example, they have chromosomal instability, and we should not treat these patients with growth hormone by no means, because we can produce important side effects, including death. Therefore, growth hormone is not indicated. And some syndromes, like floating harbor syndrome or Kabuki syndrome, we still don't know whether they could benefit from growth hormone therapy. So some studies are being done at that moment in order to know whether growth hormone therapy could be success or not.
Thank you. The other question is, Dr. Haider is asking about the differential diagnosis for short stature with retinitis pigmentosa and skin lesions. And this is, I think, directed also to Professor Jesus.
Could you repeat the question, please?
Yeah, short stature with retinitis pigmentosa and skin lesions. What is the differential diagnosis?
Well, the differential diagnosis here is very important, but we need to take into consideration symptoms like Bloom syndrome. And of course, the PLK4 mutations expressing the syndrome that I mentioned that could have not only chorioretinitis, but also blindness in these patients, as I saw in one of the slides. So this differential diagnosis should be always done.
Thank you. Professor Rasha, what's your opinion in using oxandrolone in girls with Turner syndrome diagnosed late to improve their final height, like in the presented case?
Yeah, okay. Actually, in the presented case, I did not use oxandrolone. We don't have oxandrolone in Egypt, but in the guidelines, it's very strict indications. It's not routine use. If the girl is going to have a very short final height and started growth hormone late, it is moderate. It is a strong recommendation to start oxandrolone 0.03 to 0.05 milligram per kg above the age of 10 years. And of course, it's very important to monitor for virilization and the breast size and the lipid profile. It's not something straightforward thing to follow, but in certain indications.
Thank you, Professor Rasha.
Thank you.
Dr. Mariam is asking, Mariam Bushail, when is the ideal age to start growth hormone in a case of Turner syndrome? And what's the age ideal to start the hormonal therapy?
Okay. Also based on the guidelines, most of the guidelines agreed that growth hormone around the age of 4, okay? Although what I do, if I'm lucky to diagnose Turner earlier, I start if they are short. If they are very short and not yet 4, I think we should start. And for the sex steroid, it's a matter of debate. Like I showed you various references, but most of the references agreed from 11 to 12. Most important is the old assumption that we give a very low estrogen in the prepubertal period or delaying it until after 15. This is not recommended at all. So the range of the age is 11 to 12. We can play with this range according to the height and other factors.
Thank you, Rasha. The other question deals with Turner syndrome, short and delayed puberty. Can we delay the introduction of sex steroids since she had delayed bone age to improve the final height?
Yes, I nearly answered this question. Yes, you can delay it, but what I think is that don't delay it more than 13. Because as I mentioned, if you delay it until 15, like the old references in the old times, she's losing a lot. It has got deleterious effect on the bone. You need it for a lot of things to act with the growth hormone to achieve a growth spurt. You need it. So we don't need to delay it a lot. The actual age is 11 to 12. If you consider yourself delaying, make it 13. I don't know what Jesus thinks. What do you think, Jesus?
Yeah, I completely agree with you. I completely agree. I also would like to mention that we don't use oxandrolone anymore, and it's not commercialized in Spain at that moment. And I think that regarding starting growth hormone therapy in Turner syndrome, we start around 2 years of age. That is an important issue. And I would like to ask you one question. In your talk, you did not mention in patients with Turner syndrome and mosaicism in the karyotype, the percentage of cells 45XO and 46XY. I guess this is an important issue because, as far as we have more cells 45XX, then the height of these patients
it was 65% the triple X. It's written in the slide, but I was trying to finish fast. It was 65%.
Yeah.
The majority was the triple X, and that's why the girl is tall and she doesn't have the typical delayed puberty. A very good question.
Yeah, I think that if you can speak faster in your mother language than in English.
I speak fast, yes, that's true.
You really do. Okay.
Thank you.
Thank you.
The other question is also regarding Turner. As prophylactic gonadectomy indicated in Turner syndrome cases with Y chromosome?
Yes, this is another debatable. It is indicated, yes, but the debate is on the timing, when to do it. Most of the references, and I'd like to hear Chris's opinion as well, mention that it's at the time of puberty. We should not wait until after puberty because it could turn to gonadoblastoma or dysgerminoma. But the question is, what if we discover the Y chromosome earlier in a child? Shall we remove the gonads that early or not? This is the debatable point. But at the time of puberty, it should be removed. What do you think, Jesus?
We are doing more and more surgery through laparoscopy when we don't see any ovary in the ecography. And I have a lot of videos. I can send you one example if you want, because it's very fast. We can recognize the small ovary that you can find in these patients, and we like to perform laparoscopy and removing the small ovaries of the residues that you can find there.
So you remove it at any age, or do you wait until puberty?
No, we don't wait till puberty. As far as the diagnosis is made, especially in patients 45 XO, or most of the lines being 45 XO, then after performing ecography and showing that we don't see any tissue in the ovaries, then we like to perform laparoscopy. If the laparoscopy shows macroscopically that you have a small residue of ovary, then we remove them.
Yeah, thank you.
I think this is very important, and sometimes it might be difficult to convince the parents, but maybe a multidisciplinary meeting could help a lot in that case.
Yeah, very difficult, yes.
Thank you. Another question, Dr. Mariam has a case of disproportionate short stature. The diagnosis is still unknown despite doing a gene panel. The parents were asking about growth hormone therapy. Can it be started empirically or after doing the stimulation test, or the diagnosis is important?
Well, I mean, if you identified, minor signs of dysplasia, or if you have a diagnosis of SOX mutation or any abnormality in the PAR1 area, then at that moment, as you know, the indication for growth hormone therapy, as in Turner syndrome, due to haploinsufficiency of the SOX gene, is indicated. However, it's indicated if patients are below -2 standard deviation. And in my opinion, we have more than 100 families with Léri-Weill syndrome. Approximately 50% of them, the kids don't show short stature below -2 standard deviation. We do not treat them. However, when they are below -2 standard deviation, we treat them. And the percentage of success is quite different, because when they get the final height, normally, we don't get many centimeters in advance. Therefore, in my opinion, today, the treatment with growth hormone therapy in patients with Léri-Weill syndrome is a question mark. We need to learn more about different investigators in the world, and we need to learn exactly if we are getting any benefit or not to this patient. You cannot forget that patients with Léri-Weill and Langer syndrome, they have many problems in their articulations, and they suffer a lot of pain when they are adult. Don't forget that this is a rhizomelic dysplasia, and therefore, as I said, the success of growth hormone therapy must be analyzed with many data, with many patients from many researchers around the world.
Yeah.
Thank you, Professor Khassas. The other question is for Professor Rasha from Dr. Ilham Al-Amiri. Why should we do FISH SRY if we have a Y-containing karyotype?
You're just confirming, but to be honest, yes, if you can see the Y chromosome clearly, you will not do it. But in this case scenario specifically, the one that I showed you, the parents did everything. They were mad. They were crazy knowing that their daughter has got a Y chromosome. So they were doing it aiming that she doesn't have a Y chromosome, not to confirm. So I just put all the data of the case. But if you are sure that this is a Y chromosome, yes. Sometimes it's not very clear in the karyotype. It is suspicious. In such a case, yes, we confirm by the FISH. And of course, it is expensive. If the parents cannot afford, yes, we can just rely. But what I think is that, and I need to hear Chris's opinion, if we are planning to remove the gonads, I think we should do the FISH. What do you think, Chris?
Well, I think that you can, the karyotype is clear and the number of the average of cells in mosaicism are clear, I don't think you need to do the FISH. It's not necessary. If the clinical findings and the molecular findings agree with typical Turner syndrome, it's not necessary. Particularly if you are planning to remove the gonads, then you can do in the tissue that you remove any kind of studies, including FISH, if you want to complete the study. But I don't think it's necessary to do it in advance before removing that.
Yeah, thank you.
You're welcome.
The other question is from one of the attendants. Her daughter is 11 years old and she's 131 centimeters in length. Her bone age is equal to the chronological age. Thyroid hormones and TSH were normal, but since 1 year, her length didn't increase. She received only vitamin D. What should we do for her?
What about her puberty, mid-parental height? Some data are missing.
Exactly, lots of data.
Yeah, the mid-parental height is important, the stage of puberty. But if the bone age is not advanced, then she doesn't have a pathological problem. It seems so, but some data are missing.
I agree.
Yeah, exactly. We need to take more history and
examination.
A question from Asma, our president. Hello, Asma. When would you advise genetic testing for short stature?
Asma, this is a very important, difficult question to be answered rapidly. But following our algorithms, I think it's very important to see whether the short stature is proportionate or disproportionate or is syndromic. If there is a prenatal or postnatal short stature, if prenatal, if the patient exhibit microcephaly or not. According to this, we can address the different kind of genetic studies looking at either the phenotype or the genotype. If you consider that the patient could have an isolated growth hormone deficiency, you can do either Sanger sequencing or perform a panel of genes to analyze different possibilities. If you consider that the patient could be a Russell syndrome, then you need to do specific studies for chromosome 7, 14, etc. If you don't recognize anything, you can perform an exome, a full exome, to try to analyze different possibilities. If you consider the patient could have a growth hormone resistance, then you can do either Sanger sequencing or panel. So there are different possibilities according to the potential diagnosis. And if you have a genetic syndrome, as we discussed today, and you don't have any specific diagnosis, then go directly to perform a full exome. If you have a potential diagnosis like a 3M syndrome or like a floating harbor syndrome or Kabuki syndrome, then you can explore by Sanger sequencing the specific genes that are involved in this issue. If you have a spectrum of Seckel syndrome, then, as I mentioned before, you can do either a panel including all of the genes we know so far, and if all of the genes are negative, then you have the right to perform a full exome in order to find a new potential gene involved. So from the very, very clear patients with proportional short stature to the very, very complex patients with genetic disorders, we have today many tools to address the genetic study. And it is important to do it, number one, because we need to perform a genetic counseling, an adequate genetic counseling. Number two, we need to know exactly the diagnosis of the patient. And number three, because according to a diagnosis, we could do a proper treatment or to avoid to use growth hormone if it's not appropriate.
Thank you, Professor Jesus. The other part of the question is also for Dr. Asma. I think you have already answered that. If the child doesn't have a recognizable syndrome, what genetic test would you suggest? I think you've already answered.
I already answered.
Yeah. So the other question to Dr. Rasha about oocyte preservation and whether it can be done for females at an early age for future pregnancy, and whether there are any success studies.
There aren't clear successful studies, but there's a lot of research on that. And there are predictors, as I mentioned, the FSH level, the anti-Müllerian hormone, the inhibin B. In those who there is some hope, especially, of course, in mosaics, there are trials of preserving, but there isn't clear research mentioning that, yes, it's there and it's working, not yet. But I think it could work at a time, but in special turners, not in every turner. I think it would be so difficult or impossible if this is a 45X turner, for example. And of course, the predictors of the function, like the anti-Müllerian hormone and the FSH being the most important. In Egypt, we do not do it. Is there any work on this, Jesus?
Yes.
Oocyte preservation.
Yes, we are doing some work, and there are 3 places in Madrid, in Barcelona, and also in Pamplona, where we are working on that, and we are preserving the oocytes in order, and we have some cases with success having fertilization. Yeah, but it's
very good. So it's been tried, then you have the results even.
We have some patients with good results and some patients with bad results, but it's very expensive to maintain the infrastructure, because you need very, very special issues. And at that moment, the main problem we have is that most of the Turner patients finalize in abortions when the mother is pregnant.
Malformations. So, yes.
In fact,
and at what age, Jesus, do you preserve the oocyte? What's the optimum age that you take the oocytes to be preserved?
Well, as soon as you can. I think this is the most important issue. But we don't know. We don't do that before 6 years of age. Okay.
Okay. Thank you.
The other question, I think we've already answered it. Is it advisable to do karyotype for all short stature females? Yes, we should.
Of course. And even for males.
Yeah.
Again, we have another question from Professor Asma. What is the preferred maintenance sex hormone and Turner syndrome?
The preferred, sorry?
Yes, the preferred maintenance sex hormone and Turner syndrome.
What's written in literature is, you mean the estrogen, sex steroid to start with? I don't know what Asma means, to start with estrogen or to add progesterone and continue maintenance in what stage? Anyway, the preferred regarding the estrogen, what's written in the article published in JCM is the transdermal. But of course, it's a matter of availability. Because, for example, in Egypt, we only have the depot form. We don't have the oral micronized, and we don't have the patches. We have the intramuscular depot form. But what's written is the transdermal patches followed by the depot form. This is for the estrogen. I mean the estrogen. I hope I got the question correctly, Asma.
Thank you, Rasha. The other question, the decision to start growth hormone, should it be made by GP or general pediatrician or by specialized pediatric endocrinologist?
Definitely specialized, but sometimes there is malpractice. What happens, I'll tell you, in Egypt, for example, sometimes the general pediatrician keeps treating and managing the child until things go wrong, and then he refers the child. There is a part of practice like this, unfortunately, but of course, this is not the right thing. I showed you real stories. This is what happened really with those girls, but of course, this is not the right thing. The right thing is to refer the case once there is suspected endocrinal problem. What do you think, Jesus?
Yes, definitely specialized. It's very important when you are training young doctors and they have the diagnosis of Turner syndrome. They want to go immediately to put growth hormone. Sometimes before knowing the blood pressure, sometimes without knowing whether is there any cardiac malformation, especially coarctation of aorta, or a kidney malformation. And we have patients that died due to the coarctation of aorta. So therefore, it is very, very important to recommend growth hormone therapy by pediatric endocrinologists once a Turner girl has been properly studied, and we have analyzed the cardiac function, the kidney function, the blood pressure, and we have the clear idea that we're going to start therapy with growth hormone.
Yeah, I totally agree. And I think even once the general pediatrician catches a case of short stature, he or she should refer, because as you've seen in the cases, they were not even diagnosed as Turner. They kept being treated with growth hormone deficiency doses or as cases of hypothyroidism, Hashimoto, until the diagnosis of Turner was very late. So even this is another problem. They do not know that this is Turner case, especially if it's not the typical dysmorphic.
This is the way it should be, no doubt about it.
Yeah.
I totally agree with you, especially that growth hormone has many indications and each indication has special specific dose. So it's very important to be followed by pediatric endocrinologist. Thank you.
Definitely, yes.
The other question is, what is the age to refer Turner syndrome to pediatric endocrinologist?
Once diagnosed.
Immediately, yeah. Any other question? Does growth hormone help Turner to reach accepted range for mid-parental height?
Yes, but there are a lot of factors that affect the response. As I said, there are parameters for successful outcome, early age of onset, mid-parental height, overcoming the waning effect by increasing the dose, the duration of treatment, adding sex steroid 4 years later. A lot of factors affect, but generally speaking, of course, those who are treated will have a better final height than those who are not.
Yep.
Someone is moving the questions very fast. With that, do you give vitamin D with growth hormone and Turner syndrome? If yes, what's the dose?
I don't give it routinely. I give it if the child has got vitamin D deficiency. It's not something, especially that those girls are liable to low bone mineral density and they have cardiometabolic problems and other problems. So yes, it's good to give it, but you should be sure that the girl is vitamin D deficient or has got low bone mineral density. According to the situation, it's not something routine that I do in every Turner girl.
Rasha, I have a question for you. What kind of IGF-1 levels do you see in patients with Turner syndrome under growth hormone therapy in your Egyptian patients? Are they very high?
No, surprisingly, most of them are not very high in spite of giving the doses. And sometimes because of the late diagnosis, we have to reach higher doses of growth hormone, not the 0.04, maybe higher. I don't know why it doesn't exceed. Is it related to the assay? Is there genetic susceptibility in the response to growth hormone and causing side effects? I really don't know, but most of them do not reach above normal levels. Most of them, not every case. And
that's interesting. In our case, it's just the contrary. Most of the patients with Turner syndrome under growth hormone therapy exhibit very high IGF-1 levels.
And even on the ordinary 0.04 doses, or you reach very high doses?
Absolutely. So we understand this issue because those patients are not growth hormone deficient. Therefore, with a dose of 0.04, 0.045 milligrams per kilogram per day is enough to dramatically increase IGF-1 levels.
Yeah.
This is one of the reasons why internationally these patients that receive growth hormone therapy are followed for potential carcinomas in the future.
Yeah, and diabetes as well. There are some research that they have inherent susceptibility to diabetes, but A1C should be followed as well in those girls.
That is correct.
Professor Kaisis, I have already as well noticed that the IGF-1 is high in my patients with Turner who are on growth hormone, at least on the upper border of the normal.
Yep. Okay.
The other question is, some questions are repeated, so we'll pass through them. Do you routinely screen for celiac and every case of Turner syndrome? And if negative, will you repeat it annually?
Yes, I do this. I screen for celiac every year. Yes, because I've seen a lot of silent cases with silent celiac in Turner syndrome. I do this. Jesus, what do you do? Do you screen yearly for celiac in Turner girls?
Always. It is very important. Another question for you, Razia, is how many patients with Turner syndrome and diabetes do you have?
Not a lot. I have a lot with thyroid and celiac. I have maybe 3 cases, and I see a lot of Turners, let me tell you. So I think 3 is very few compared to the number of Turners that I see.
Sure, absolutely, because it's classically defined as a potential association in Klinefelter syndrome, Turner syndrome, etc. But the number of cases associated with diabetes type 1 is really, really small.
Yeah. And the 3 of them are 45X. The 3 that I'm telling you about are 45X Turners. Maybe it's related to the karyotype, probably.
Thank you.
Thank you. The other question is about the cardiovascular assessment before sex steroid therapy. Will you do it just with an echo or MRI?
For me, I'll do it with an echo. I think there's no need to do an MRI, except if there is a real abnormality that I need to look for. And Jesus, do you do an MRI routinely?
MRI is not indicated. Abdominal MRI is not indicated. Echography is more than enough. And if you have an echographist with experience, the information is very relevant.
The other question is about scoliosis and growth hormone. Do you use growth hormone in cases with scoliosis? And what's the accepted degree of scoliosis to begin treatment?
For me, classically speaking, if the height is not compromised a lot, I will wait. I will not give growth hormone. For example, if the child is -2 or -2.2, I will not risk it. But if the final height is going to be very short, sometimes and the scoliosis is not severe, what I do is that I start on a low dose. I follow up with a pediatric orthopedic surgeon. We do the x-rays. He follows the angles. I don't measure. I just look. But the one who follows up accurately and tells me stop or continue is the orthopedic surgeon. But this is in very limited cases. Of course, this is not routine. The general rule is if the child is not very short and he has scoliosis, I would not give growth hormone. What do you think, Jesus?
Well, we have the limit in 15 degrees of scoliosis. And this question is very important, particularly for patients with Prader-Willi, because we have the experience to see how an scoliosis can dramatically increase in short period of times, including 3 or 6 months in the follow-up. So we need to pay attention. Scoliosis is a sign to pay attention and to control strictly growth hormone therapy. And if the degree of scoliosis is greater than 15 degrees, better not to continue therapy or not to start therapy.
The other question.
Okay, and what if the child is very short, Jesus? If the child is -4 standard deviation, for example, and the degree of scoliosis is more than 15, what will you do? Because we face cases like this.
Well, you are in front of a patient before having short stature. This patient has a skeletal problem, and that's really important. And you know that growth hormone therapy can create a higher problem in terms of scoliosis. Therefore, I would suggest, to be again, if the scoliosis has more than 50 degrees, more than 15 degrees, I would not be pro of using growth hormone.
Okay, thank you.
The other question, will you give growth hormone for short cases with osteogenesis imperfecta? What I know is that it's not indicated. What do you think, Professor Jesus?
No, it's not. Growth hormone therapy in osteogenesis imperfecta, no matter what the type of osteogenesis imperfecta, is not indicated at all.
Yeah, it's so, not the classical treatment. Yes,
we have some data in the literature, but you know, the problem of these patients is tremendous, and growth hormone is not today is not adequate therapy for osteogenesis imperfecta.
Okay, the other question.
Yeah, but some patients come asking for it. This is true, Haya. This is a very important question, because I don't know with Jesus, but in our country, in Arabs, they come saying, we need to take growth hormone. We are very short. We keep explaining, you are not short because of growth hormone deficiency. It's a bone problem. But they are really, really stuck with the idea of giving growth hormone. And there are some, yes, trials, but very few trials. And of course, it's not the classical thing to do.
Sure.
We're seeing the same as well. The other question is about 6 priming when you're doing a growth hormone dynamic test. Do you do the 6 priming or not?
Jesus, do you do it or not? This is another debate.
We like to say that the fetus is already imprinted, so we don't use this kind of stimuli.
You don't do it at all, huh?
No.
Because some still do it. I don't do it, but some still do it, insist on doing it.
Some people still do it, but as I said, the fetus is already imprinted intrauterus.
Yeah, very nice description, Jesus.
We have another question from Professor Khalid Hussein, directed to Professor Rasha. There are cases of Turner syndrome due to ring chromosome and hypoglycemia. Do you know what the mechanism might be?
I really don't know what is the mechanism. And when I speak to Khalid Hussein about the beta cell, I will not add anything. The ones that I have seen with ring chromosome are the ones who have severe mental retardation. This is the thing that I have seen, and this is what's described in literature. But I haven't really passed across a case of Turner ring chromosome having congenital hyperinsulinism, or is it just hypoglycemia? I don't know what Khalid means. Is it congenital hyperinsulinism or no? How did he describe it, Haya?
He just mentioned with hypoglycemia.
Hypoglycemia only. Yeah. I haven't passed through something like this. I have seen cases with diabetes type 1 and type 2, but I haven't come across a specific case of ring chromosome with hypoglycemia. Jesus, what about you?
Oh, I agree with you. I have no further comments. I agree with you.
Yeah, of course, Khalid Hussein has seen all the hypoglycemia cases in the world with all their forms, so he came across maybe a case of Turner like this.
Yep.
Okay, the other question, and this will be the last question because we pass our time, is from Dr. Hala Al-Sheikh, who's our colleague as well, and ASPED. The question is, how about achondroplasia? Do you use growth hormone therapy for treatment?
Well, we don't use growth hormone in achondroplasia. We have some studies performed in Japan, getting some moderate results, but we don't use it. We don't use it in Europe. It's not an indication by the EMA. It's not an indication by the FDA. And today we are trying to find new therapies, new proteins for the treatment of achondroplasia, but not growth hormone.
And what about hypochondroplasia, Jesus? Do you try it in hypochondroplasia?
Yeah, some people try it in hypochondroplasia, but the first thing to define is what hypochondroplasia is. Because we know today difficulties in the diagnosis of hypochondroplasia, but the idea in Europe today is not using growth hormone either in patients with hypochondroplasia.
Yeah.
Well, unfortunately, we come to the end of our growth webinar, although there are many questions and the The topic is very interesting.
Yes, Jesus has another webinar. We don't want to leave you, Jesus, but I know that you have another webinar.
I want to stay here, and I want to.
We want you to stay with us.
We need to continue discussing endocrine problems because obesity, central precocious puberty,
everything.
Whatever. I love that. I love that,
yeah.
and I love to
glad. Yeah, would be glad to have you.
So I would like to thank Professor Jesus Argentay and Professor Rasha Hamza for giving us their precious time, and would like to thank ASPED for the organization of these very useful webinars, and thank Sandoz for their sponsorship, and thank you all for your attendance and participation, and hope to see you in a week's time with another webinar, which is about leptin therapy. Thank you very much, and wish you all the best.
Thank you. Thank you, Haya. Thank
you, Rasa, for all of the organization.
Thank you. It's a real pleasure having you with us. Thank you, Haya, for your excellent moderation. Thank you very much.
Thank you, Rasha.
Thank you. Have a nice weekend. Bye-bye.
Thank you. Bye.
Bye.
Thank you. Bye-bye.